Everybody, I am so happy to be able to introduce to you our guest for today, my very dear friend, Frank Anderson. Frank is a psychiatrist who has been in the trauma field for centuries, as have I, and and is an expert both in IFS and working with parts, and also in psychopharmacology. You've always actually been my go-to expert uh, because the psychopharmacology of trauma is not your standard psychopharmacology.
Percent.
And Frank got his start talking about psychopharm, but very quickly was recognized as somebody who is really inherently a clinician and can has helped hundreds of thousands of therapists work with their most difficult cases, um, and help people who haven't been helped finally heal. So, and he's the author of 4 books. Four?
3 books.
Sorry,
Shows our age when we're like, can't even remember how many books. It's so, I have to tell you, Janina, and I'll tell folks the books, but I had this Austin, my youngest son, who's finishing his last 2 days at his high school, moving on to a new high school next year. And he had this flurry of activity. Papa, I need all your books and I need you to sign them because everybody in my school wants copies of your books. And it was the cutest thing. It was the cutest thing. And Austin has not shown any interest in any of my books at all. But all of a sudden, at the last moment, so I got some on the shelf, but I emptied the shelf of a lot of the books because in his last hurrah with his school, he wanted to pass them out, which I think is just so sweet, right? In his little pride, he's like, so my most recent book is To Be Loved, which is a memoir, a story based on truth, trauma, and transformation. And the memoir is really, for me, my personal trauma history, my story, and holding both worlds, right? As an expert as well as a survivor. Happy to say that I was just off a meeting today working on turning it into a feature film. So we'll talk more about my production company. I'm thrilled to be able to bring that information out to a larger audience.
Wow.
Austin was like, make sure you give them the book with the pictures. I want people to see me in your book. I was like, okay, honey, I will, which is very sweet. My second book is Transcending Trauma. And, I kind of think of that, Janina, as was my first major book around my life's work. It really was at the point integrating internal family systems, neuroscience, and for the treatment of complex PTSD. And that was really an important book to kind of get out there in the world. Maybe your fragmented book is similar to that. I don't know which one kind of for you is that one, but that was kind of putting my work out there in a way that was important. And then
and it's a workbook, right?
no, the other one, the first one. So I'm going in reverse order.
Oh, okay.
The first one is the IFS Skills Training Manual. And
Oh,
that one is a workbook. And boy, talk about timing, right? Like that was early on in the workbook stages of things. You had your workbook, I had mine, and that was as IFS became super popular, it was like the Bible and the gold standard. Like that book has sold so many copies. Like it was a way for people to access the how-tos of IFS. So it was a very, very popular book. And so, yeah, never in a million years, Janina, did I think I would be an author. Like I'm a teacher, I'm a psychiatrist, I'm a therapist, but after 3 books, I guess I'm an author. And I know I have one more in me. So when you said 4, that was accurate. And
oh, okay.
I'm working with different publishing companies now to figure out who best to go with. And I'll tell you my 4th book, which is part of what we'll talk about, really I really have a mission to bring trauma healing to the general public. I just don't think there's enough therapists in the world. And in order for us to solve this enormous, ever-growing problem, we have to figure out a way to reach folks that can't afford it, folks that aren't interested in it. So that's my next big project.
Well, and I absolutely agree. I think it's such um there there is I mean there's no way to reach everybody. I mean,
Yeah.
imagine people in South Sudan are not going to have much access to therapy. And you probably do too. I get emails all the time from desperate people saying,
Yeah.
I
Yeah.
don't have any money, right? I live far away. I can't get to a city. Can you find me a therapist?
Right. That's right. Yeah, yeah. And just recently, about a month ago now, I had spent a week in China in Beijing. Similar situation, beautiful country, lovely people, so much trauma and not a lot of access, right? It's not
Yeah.
even really allowed in I think mental health is not even really allowed in certain ways in China. And yet this organization created this peer-to-peer support group, which is so beautiful.
I've
People,
heard them talk about it.
yeah,
It's amazing.
it's amazing. 2,500 people they have in their group, and,
Yeah.
and they have all these levels of skill, and it's very clearly supported. It's structured very well. Hailan is the woman who kind of created this. But those kinds of things really inspire me to kind of how are we going to solve this problem together?
Right. Right. That's wonderful. And your book will provide the information.
That's right. That's right.
And I think that's one of the things you and I have always had in common is is believing that people need information.
Yes, that's right.
They
Yeah.
don't they don't just need therapy. They need information.
It's the Wild West. Like I think about people that don't know, like look at all the models of therapy. How in the world would you go to a therapist when you have no idea? It's not like you go in and you have an infection, you have tonsillitis, and there's 3 antibiotics that you can choose from that will heal that. That's much more clear and straightforward. So people that aren't familiar in the mental health world, like, do you want a CBT therapist? Is AEDP better for you? IFS, sensory motor? Like people have no clue.
Right.
And they just find a therapist randomly with no idea about what would work for them. It's a whole different world in that way.
And the therapist, I look at therapist websites all the time, and therapists don't necessarily say, I do EMDR.
Yes.
It might be listed under the methods they use, but they describe we're going to create a safe environment together, we're
Yes.
heal, and that doesn't tell you what method are we going to be using for healing.
Right. Absolutely.
Yeah.
Yeah.
And, you know, I just realized we go back almost exactly 20 years. 1995.
30 years. This is 25. It's 30 years. I was thinking of that myself, Janina. 1995 to 25.
Yes, so folks, we have known each other for 30 years,
Yes.
which does date us.
Yes, it certainly does. Yeah,
And
yeah.
yeah, and we met at Bessel van der Kolk's Trauma Center as supervisors.
Yep, that's right. That's right.
And you were probably the psychopharm sort of expert on the staff too.
At that point, yeah, I don't know. I started out with Basso. I think I started out in 1992 with him. That's when I finished my residency at Harvard. And so I started out at 92, and originally I was the psychiatrist. So I was the staff psychiatrist. I worked and treated patients for several years and was always involved in team meetings. And it's where I learned how to do psychopharmacology with trauma survivors, which is a whole different issue we can talk about, because you can't be particularly a white male giving pills, putting foreign substances into mostly women, not only with people who have been violated in that way. Like I learned really quickly, this ain't gonna work. You know, I'm the expert with all the power who's going to tell you what substance to put in your body. It was I was like, I got to come up with something different. And I did quickly in order to be able to do that effectively, give back the power to the person taking the medication instead of giving it to the prescriber, right?
Right. I remember because I remember clients who would come back to me after meeting with you and they'd say, "What's wrong with this man? He's giving me choices. Tell me what to do."
That's right. That's right. Yeah.
And I would say, "Well, it's good to have choices. What are your choices? Let's talk about them."
Yeah, that's exactly right. And it was a game changer for me in a lot of ways because you know, as a trauma survivor, like I know what it felt like to be dominated and controlled, you know, and violated. And the pill thing just felt like a replay of that, or you could do it differently. You know, it's like I educate, you decide. That's one of the things I say to all my clients when I prescribe medicine. I educate, you decide. I'm not going to make this decision, but I'll provide the education. And the other thing I say, which I know you know, is no medications are given until all parts are on board. So all parts have to agree, not just the one that says, I want a sleep med, because
Yeah.
there's going to be one that says, I need to be vigilant. I can't take a sleep med, right? So it's like all parts need to agree before that pen comes out onto that paper. Now it's all electronic, but those were really important things around. There's got to be internal consensus. And it's going to be your decision, but I have the education. Let me educate you. You decide what's right. Bringing people back to trust their wisdom because their intuition is what got violated in trauma in the first place. Their own wisdom, they've got it overpowered. So,
And medications are complicated because they have side effects
yeah.
and they don't do what they're labeled as doing. You know, an antidepressant does not take away depression.
Yeah. Yes. Well, yeah, it's one of the things I say to people all the time because a lot of people come in feeling sad and depressed and want an antidepressant. And well, let's work on symptoms, not feelings. And that really throws them off. Like, hey, you've given me Prozac and I'm sadder than ever. And I'm like, well, wonderful, it's working. Like, what do you mean? You know, it's like it takes care of the symptoms, not the emotion. That's what the psychotherapy is there for. If you can sleep and concentrate and you have an appetite, then maybe you'll be able to work on the issues that kind of created this problem in the first place and access to your feelings because depression disconnects us from what we feel.
Right,
And
right,
yeah,
right. And you know, what I always you can tell me if this is actually correct. I've always said to clients, what antidepressants do is they kind of put a floor under
yeah,
your depression. So you don't sink as low. They don't take it away.
that's right. 100%. You know, and in the IFS terminology, IFS has this term called unblending, right?
Oh, I know that term because I use it every day.
Right? It's like it also, I think of medications as great unblending agents,
Right.
meaning they help with that separation because if you have no floor and you're reliving constantly, you're not getting a lot of work done in your therapy because you're just reliving and re-experiencing. And so the unblending allows the client to be with their experience instead of in it, and so if they're not in it and they're with it, there's a capacity that they didn't have before. That's probably for me the main issue. Doesn't even matter which med it is, is to help on blending, whether it's a low dose antipsychotic for dissociation, or it's clonidine for decrease in flashbacks, or antidepressants for helping with reactivity. They all of them create the separation that makes doing the work possible.
Right, right, right. And I'm thinking about the clients I've had who've had to have what I call the trauma cocktail, who
Yeah.
had to have kind of one of each
Mhm.
because they're so dysregulated, their parts are so active
Yeah.
that it takes a lot of regulating. And 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 I think also of medications as helping to widen the client's window of tolerance.
Totally. Yeah, that's very similar to the unblending. Like if you're reliving it all the time, you don't have the capacity to work through it. So this kind of expanding that window gives you more, if you use polyvagal terms, vagal tone, it gives you the capacity to kind of be with and be in, be with and be in, that movement, that fluidity back and forth. I'm doing a lot, interestingly enough, Janine, lately, which has been very helpful. I did work with Paul Deniston, a friend of ours that you know. I did a workshop with him on embodying parts in trauma healing. It was
Uh-huh.
such a useful workshop. I learned a lot when I did that workshop. And part of this flexibility and vagal tone and expanding window of tolerance, and this was kind of surprising for a lot of people, is actually blending for a moment, embodying the posture, and
Uh-huh.
then popping out, and then embodying the posture. And it was fascinating for people because when they just talked about it, they got stuck and flooded in it. And it was
Mhm.
harder for them to get out. But when they like, show me anger, show me anger. Okay, now let's just stop for a minute. They get out of it. And they can get out of it. And they're like, oh, let's be with the anger. So it's been really interesting for me to actually sometimes embodying it helps people also know they can get out of it.
Well, it's a way to be in relationship to it
Yes.
instead of flooded. I
Yeah.
mean, I would say, probably two-thirds of my clinical time is spent helping people unblend,
Yes.
but not unblend from remembering, unblend from parts
Yeah.
that are still depressed, still afraid, still ashamed, and and the parts have increasingly started running their lives
Totally.
as the client starts to make decisions from that depressed part's
Mhm.
perspective,
Totally.
right? As blends with the suicidal part and thinks, oh, I need a plan to end my life. And so it's really not being able to have a relationship to the parts that keep
Uh,
the feeling memories.
totally. Totally. Yeah.
So those parts are abandoned, and the client's life is in in a mess.
Yeah, that's right. That's right. And medications really do help with that. Like that's
Yeah.
people, there's a lot of people in our field that are anti-medicine. It's really interesting. I kind of joke about this a lot. And some of even our friends and colleagues, this older group of like, I'm gonna say people that grew up in that hippie generation, like Gabor or Bessel or Dick Schwartz, they're kind of pro certain kinds of drugs and against other kinds of drugs. And I kind of joke with them a lot. I'm like, okay, so psychedelics are good drugs and Prozac and Zoloft and Paxil are bad drugs? Like, explain to me this, right? Tell me why you endorse this type of psychopharmacology versus that. they're kind of the same thing. They either increase or decrease serotonin or norepinephrine or dopamine, or they increase or decrease glutamate or GABA. Those are kind of our neurotransmitters. Why do you all like one group and not the other, right? And they kind of laugh back. Okay, Frank, I get it, but they're more anti-drug company, not anti-medication. And I want to make that distinction. People don't like Lilly, the drug company, but these medicines really help people, and especially when you understand the neurobiology of PTSD and dissociation, it makes perfect sense that these medicines would help stabilize the nervous system. So,
Absolutely. And I really have a hard time with, which it's more common in the EMDR world, where the therapists are taught to believe that the client has to be off medications
yeah,
to effectively process trauma.
yeah, yes,
No.
yes, yes. It's the opposite. The medication should help you have more greater capacity to process trauma. It's like they used to say in the old days around substance use. You need to be sober in order to process your trauma. Like, good luck with that one. Like when substances are the very thing that are protecting you from your overwhelming experience, how do you rip that apart to deal with it? It's kind of silly.
Right. I know because I did a postdoc in Judith Herman's clinic, and postdocs, I'm sure, like residents, do the grunt work.
Yeah.
So part of our job was to answer the phones when patients called wanting
Yeah.
to come to the clinic. And there would be these people, and I'd have to say, I'm sorry, we don't accept anyone who hasn't been sober for at least a year. And these clients would be calling saying, but how am I going to get sober if I don't get help?
Yeah, yeah, yeah. So that's
And the
exactly
same
right.
with battered wives. We
Right.
weren't able to take battered wives until they had been safe for a year.
Yeah. We've come a long way in this field, and we've been fortunate enough, Janina, and I would say that we are fortunate enough to have gone through the process. The younger generations are starting here. We started before there were any of these. Like I think about the model makers right now. I think about all the model makers. There wasn't even EMDR when we started. EMDR
No,
didn't even exist. We did the first EMDR Prozac study at the trauma clinic.
right.
So we were fortunate enough to see all the model makers show up for this field: EMDR, sensory motor psychotherapy, somatic experiencing, IFS, AEDP, EFT, all of them, and it's been lovely to see these models emerge and evolve, and to kind of have gone through the journey, because we knew what it was like before all of these options
Yeah.
existed.
Where we were winging it and trying to do psychodynamic therapy with trauma,
Yeah.
and it wasn't working.
Oh my gosh. Didn't work for me. Like I say this and it's so crazy. I mean, I loved my therapist in my residency. He was a lovely human being. He was a kind man. Thank goodness he was. But I saw him 5 times a week for 11 years.
Oh my,
5 times a week for 11 years, Talina. And I had no more healed my trauma history when I walked into that office versus when I left. I had awareness of it. I had all the story I was clear about what happened to me. I had more ego capacity, if you will, but all of the stuff was still in my body and still in my emotion. I still held my trauma. It wasn't until I, parted ways with him and then found these trauma specific treatments that actually helped me release some of this stuff I was carrying. So, again, lovely man, but well intended,
yeah,
but certainly didn't know what the heck to do with
right.
how to heal.
And you and I didn't know what we didn't know back
No,
then either.
my goodness.
Yeah,
I remember working at Charles River Hospital. You remember that hospital in
I
Wells?
do.
Oh my goodness. I was a moonlighter there to pay for my 5 time a week therapy.
Oh, well,
Like all the time there. And it was kind of tragic to see. It was one of those wealthy suburbs, for those of you who don't know Wellesley in Boston, wealthy suburb, private hospital. So the well-resourced people, mostly women. That's a women's unit that I worked on, women and adolescents who had trauma histories. And we would bring them inpatient and they would fall apart and regress. It was one after another. It was so tragic to see lawyers and doctors and accountants, like all these highly skilled, educated professional women fall apart because of the regressive techniques we had at the time. So kind of we know what not to do because of what it was.
right, because the approach they used was a relational approach, but it basically triggered child parts
Really.
who wanted to be loved. And I remember because I had a client who stayed quite some time at Charles River
Yeah.
on a couple of occasions. And the patients would talk about letting their child parts out to play.
Yes, yes, totally. Nowadays, I teach about mapping out the system of parts, and I'm always saying, but we're not mapping them out the way we used to do in the 90s because that was regressive mapping. This is about holding awareness of which parts are related to which traumas and what their relationship is with each other. Like it's a very different kind of mapping than it used to be.
Right. Now it's really interesting because I don't connect parts to individual events
Yes.
because most people don't have discrete events. They live in a traumatic environment.
Mhm.
So the parts, are carrying the effects of the whole experience.
Yeah, I mean, that's what I call a collective wound. Many of the people that have complex trauma or attachment trauma have what I call a collective wound versus a discrete wound.
Whereas
So
I call it environmental trauma
there you go.
because they're trapped in an unsafe environment.
Yeah.
And so it's collective for the parts.
Well, like they hold all of it instead of, they hold all of the wounding, so to speak. It's interesting, Janine. I don't know, never talked to anybody about this, but I talk about collective wound. I talk about parental pairing wounding, separate, I talk about well, some of the other wounds I have, multiple present day, past day wounding. I have all these different types of wounds. When I talk about the collective wound, I, almost all the times when I'm working with a client that has that kind of history, the environmental trauma that you're talking about,
Just most of our clients.
they talk about little Susie, little Johnny, little Tony. Like it's interesting. That population has a little version of themselves, but it's the young wound that kind of holds it all, which is different than, oh, I was date raped at 16, or, my parents died at so and so, or, we had a traumatic event, blah, blah, blah. So it's just really interesting to me. A lot of, those clients that really hold so much for so long, the ones you and I work with, tend to have, yeah, and I only see it in that population for some reason. I don't know why. I've never kind of talked about that before. Do you know what I'm talking about?
Well, my clients with environmental wounding have parts that, are still afraid, who still feel alone and abandoned,
Yeah.
and and they blend with those parts. And that's really the essence of the problem, and the parts trigger each other.
Yes.
So I just played a video excerpt today of my client trying to make a decision. And, you know, and there were protector parts saying, no, no, you can't do that because it's not safe. And, and, and little parts saying, but we want to go because there'll be nice people there who will smile at us. And critical parts saying, you stupid brat, how could you think
Yeah.
such a stupid thing? It was really, it was it was kind of it was actually very, very funny, mostly because my client was unblended. So she could actually
Yes.
watch and report on and be in relationship to these parts.
That's great.
That's like another day in the life of a trauma survivor.
That's the truth. Yeah.
Hey, before we run out of time, tell us about the documentary, the Body Keeps the Score documentary, because I think that is such a very cool thing.
Yeah, so never, Janina, started out as a psychiatrist, became a clinician. Now I have a production company. Like never in a million years did I think that. I was an author, and now I have a production company. So I have a company, and we're moving in. July 7th is our move date to LA, which I'm super excited about. Trauma Informed Media is a company that I formed with two producers. And we are creating content, trauma-informed content for the general public. And we have a series of different projects, which I'm super excited about. One is my memoir, To Be Loved, that we're turning that into a feature film. And the other is The Body Keeps the Score. So we're in the process of that beautiful book that Bessel has kind of changed the conversation with. I feel, honored to have been granted this opportunity to be able to turn that into a docuseries. And so we're working with a couple different production companies. We're working with investors. I was on calls today. And so this is one thing. It's interesting, Janina, making a documentary about trauma takes about as long as it does for a trauma survivor to heal. Like, this is such a long process. It's a long process. It's a long process, but we're really moving forward in ways that are really exciting. And so hopefully within a couple years, people will be able to watch in docu-series format, film adaptation of The Body Keeps the Score.
Oh,
Working closely with Bessel to kind of make sure this book and his legacy gets out there in the ways that feel true and authentic for him, because it has changed the conversation. So
oh,
super excited to be able to be working on that.
yeah, I think that's so cool.
Yeah.
And, and talk about taking trauma public to
Yeah.
the yeah.
That's Janina, we've been sitting with clients for many, many years, like a long time, one-on-one. And probably for me, after Transcending Trauma came out, my second book, I just had this like, I have to do this work on a larger scale. Just was like this, I have to bring trauma healing to the world. And I could do it one at a time, one-on-one, but there was this calling for me to kind of do the same work at a different scale. And I know you very much, in the ways that you teach, and we're getting this message out in a way that's very different. Still
Yeah,
important.
well, we got to bring it to the community of trauma
Yeah.
of therapists,
Yes.
but there's a much bigger world than just therapists.
Well, and I'm working. That's this arena of trauma informed media. It's like getting out, teaching therapists is one thing, which is great, and then reaching the general public, as we call it, is a whole different story.
Right.
Yeah.
So cool. Well, I almost hate, I feel like we could keep talking.
Yes, we can. Well, and you know what I'll say, this is another thing, the coming attractions is we will continue this
Oh, yes, that's
conversation
true.
because we are doing a workshop together in December.
Right.
which I was really excited about with my team, which is your team, saying, who do you want to do a workshop with? I'm like, Janina. So yes, in December, people will start hearing about that.
Right. And how will they get information about it? Will it be
Our
on our website?
Yeah, it's going to be, we're working on the content right now. It's a 2-day workshop. I think it's going to be 3 hours each. People will get, your email list, my email list, our social media. People will be able to see this coming. I don't know when they're going to start advertising it, but it'll be on our websites for sure and through my newsletter. So word will get out for people because we've done maybe one. I think we did a workshop many years ago. It was so fun.
We did. We had
Did
such,
we?
it was on two different approaches to parts.
Yeah,
And
exactly.
we had such a good time.
That's right. Yeah, it's lovely to, Janina, one thing I'll say, and we've had this reputation for kind of ever. It's like, oh, your most challenging people, send them to Frank and Janina. Your most challenging people, Frank and Janina. DID, Frank and Janina do that work. Like you and I have had such a lovely relationship together, personally, of course, and then as reputation of working with the people that other people don't or can't or don't want to.
Right. And supporting each other and working with those
Totally.
very complex
Yes,
folks.
absolutely.
Well, lovely to see you.
Same.
Thank you so much for doing this.
Yeah, thank you for having me.
And to be continued.
Absolutely.
Okay.